Hello and welcome to this short video where I'm just going to be talking about the basic airway and breathing, talk about some of the mechanisms and some of the things that are happening and some of the things we can look out for. So this is a nice basic level just as an introduction to get an understanding of the theory and the concepts between airway and breathing, what goes wrong and what we can do about it. My next video following on from this will be around circulation, and it kind of progresses in that way. So I'm going to be using the whiteboard to draw some. I'm not the best drawer in the world, and I've got some models to explain some bits and pieces as well. I may not be 100% technically correct, but the analogies that I'm going to use, get the words out, teeth in, hopefully will help you to understand this at a nice basic level. So I'm going to start with a drawing for you. So we're going to start here. This is the diaphragm. So we're going to be looking at the mechanism of breathing. So this is the diaphragm just underneath the rib cage, a nice sheet of muscle which will lower. So it goes into its dome shape and then it will lower and it will cause something to happen to the lungs. So let's put the lungs in place. So here is the right lung. Generally, the right lung has 3 lobes, and this is the left lung. So there's the cardiac notch in the left lung, and generally the left lung has 2 lobes because of the cardiac notch. So while we've got a cardiac notch in there, I'm just quickly going to draw the heart as well. The heart has 2 sides. So first of all, the right side of the heart generally, or it does deal with the venous blood, and then the left side of the heart, which deals with the arterial blood or the oxygenated blood. But we'll talk more about that later on. We just draw the atria and the ventricles, just so they're split up. So we'll come on to that in more detail. We've then got the airway. So the airway is got the big trachea. So just do this up here for you. So we've got the trachea coming down, and we know that there's a gate at the top of the trachea, the epiglottis, which is controlled by the tongue. But when the trachea comes down into the lungs, it branches off. So it branches off. So these are the bronchus. They will then branch off smaller. So they'll be into the bronchi, and then they'll branch off smaller again. So if we just follow one route down, each of these is getting smaller and smaller. And as it comes down, in the very bottom, we get these air sacs, the alveolar. Okay, so they're the important bit, obviously not drawn to scale, but this is the basic concept of what we're looking at. So at the moment, if we think about the airway, although it's got a gate, the actual airway is just dormant. It's just the root. It doesn't do anything. When we talk about breathing, there's an actual mechanism to cause the breathing. So the airway is always there, depending on whether the gate is open or not, which we can talk about. But the breathing needs a mechanism to make it actually work. Okay, so that's the first concept we've really got to understand. Let me just grab this here for a moment. So if we think about that airway, what have we got here? So we've got our nostrils and our mouth and nose. This big bit here being our tongue. And down the bottom here, we've got our trachea, which is here. The gate I was talking about is here, which is the epiglottis. And that is controlled by the tongue. So this epiglottis here, sorry, this bit, is controlled by the tongue when we swallow. But actually, that swallowing movement makes the trachea come up towards the gate as well. So when we swallow, the gate closes the trachea, allowing any food or drink to come down this pipe at the bottom, which is the esophagus, our food pipe, which goes directly to the lungs. So the mechanism for the airway being open, well, it is open. We close it to swallow and to send food and drink down to our stomach via the esophagus. So it is open. But the tongue here, being a muscle, if we lose consciousness, the muscle will relax and that tongue will relax against the epiglottis, which will then close the gate over the trachea, but not as efficiently as if we're conscious when the trachea comes up towards it, but as potentially will stop any air going in and out of that area. So one of the things we need to do is make sure the airway's open. There's a number of techniques we can do to help open the airway in an unconscious patient, and that may be head tilt, chin lift. It may be the jaw thrust. It may be putting something underneath the shoulders. All of them different actions are designed to help get the tongue off of the epiglottis to open the gate to allow breathing to take place. So there's the basic concept. When we go into our other lessons, we'll be looking at nasal pharyngeal airways, oral pharyngeal airways, supraglottic airways. We'll be looking at additional devices. But for now, we're going to keep this nice and basic and look at basic techniques, get the airway open. Once the airway is open, so we're going to come back to the upright position, we're then going to be looking at these lungs. So if we look, this is what I've drawn for you. So we've got the trachea up here and we've got the lungs. They branch off, and as you can see, they branch off smaller and smaller and smaller to every single little part of the lung. So that's what we're going to be concentrating on now. So moving on to the mechanism of the actual breathing. So this is the diaphragm, which will go down. As that goes down, it creates a vacuum because all of this is in a sealed area. So this would be the rib cage, the thoracic area. It's sealed. The only entrance in and out is via here, the airway. That is it. So when the diaphragm goes down, it creates a vacuum. Everything gets sucked inwards, which means air needs to come into the lungs. That's how it works. So because of that, when air comes in, we need to break down air. And if we break down air, we've got 21% oxygen in it, or 20.8. So some books say 20, some say 21. If we look at the official 20.8, we've also got some nitrogen in there, probably the biggest proportion, a little bit of argon and other stuff. But it's the 21% oxygen that we're going to concentrate on now. So that actually room air gets drawn in because of the diaphragm coming down. So on this little model here, so again, this represents the same thing. This is the trachea. This is the branching off, so the bronchus going into each lung. And then we've got each lung hanging. This yellow bit down here is the diaphragm. So I'm going to bring this in closer. Look what happens when I pull the diaphragm down. The balloons, the lungs, inflate within the thoracic cavity. When the diaphragm goes back up, I don't know if you can see that on there, but the lungs empty. So you can see the balloons there have emptied. That's what happens when the diaphragm goes back up to its relaxed position. And then as the diaphragm comes down, they fill up. I know these are stuck together a little bit, but up and down, that is our breathing mechanism. So that is how we breathe. So if we put some numbers with this, and I'm going to use some abbreviation. So we're going to look at RR, which is for respiratory rate. That should be between 12 and 20 for the average adult at rest. We would get concerned if it becomes less than 10 breaths or greater than 30 breaths per minute. Okay, so these are important numbers that you now need to know. So the respiratory rate in the average adult at rest would be 12 to 20 breaths per minute. If it becomes less than 10 or greater than 30 breaths per minute, that's when it's going to cause us concern. But remember, we never ever diagnose on one thing alone. We'll always use that diagnostic triangle, and I'll take this off in a second. But with our diagnostic triangle, we've got our history, our signs, and our symptoms. Okay, so that's what we look at when we diagnose. So just put a little D in there. So to diagnose, you need a history. So again, if someone's just been running, we expect their respiratory rate to be faster. If someone's taken drugs, we may expect their respiratory rate to be lower. But the reason why we use history, signs, and symptoms, if there's a problem with somebody's breathing, we get signs and we get symptoms. Signs, things we can see, symptoms, things the patient can tell us. So what kind of signs would we get if somebody wasn't getting the right amount of air in and out? Well, this is where they change colour potentially. So they may go a bluish tinge known as cyanosis. And that is a sign of hypoxia, low oxygen levels. So that's something we're going to kind of come into a little bit more. But for now, we're just talking about the mechanism. So breathing mechanism, the diaphragm comes down, causes a vacuum, air comes in through the trachea, so past the gate to the bronchus, to the bronchi, breaks down all the way to the alveolar. So these alveolar down here, obviously the size I've drawn them, these are microscopic. So these are tiny little air sacs. This is really important because this is where the respiratory system joins the circulatory system. So that's where the link is here. The respiratory system and the circulatory system join at the alveolar because that's where we get an exchange of gases, and it's the circulatory system that carries the gases around the body. So we'll kind of come on to that in a little bit more detail. So 12 to 20, important figures, less than 10, greater than 30, with the relevant signs and symptoms, there's action we would do. The other thing we need to do is, what are we measuring? How do we know if it's efficient? So again, looking at some of the recognition features, some of the signs and symptoms, well, something else we might have is something similar to this, a pulse oximeter. So something like this. This is just an example of one. This is a finger pulse oximeter. And really simply, if I open this up, some you switch on, this one, you put your finger in and a little red light comes on inside it. And let me just see if I can get, so I don't know if you can see the red light in there. So the finger goes in there and that red light has a sensor on the other side and it shines through my finger. So there's some common sense things. If I've got extra nails on, nail varnish on, dirty nails, anything like that, then that red light isn't going to penetrate through. So I might need to turn my fingers sideways, for example, rather than having it flat, or clean the finger first, or remove the nail varnish, etc. Also, if there's ambient light around and that kind of is shining in there, it's not going to be as effective. It's not going to pick up on the sensor. So sometimes we see people covering it to remove the ambient light. They also don't like vibration and shaking. So in a moving vehicle, or, you know, if you're leaning against a washing machine that's running, things like that, it doesn't like the vibration. So it likes to sit there. Someone with maybe Parkinson's disease or the shakes, again, it's not brilliant. Most people go for the index finger, but actually the middle finger probably has more blood vessels and a better rich oxygen level at it. So sometimes the middle finger is better. And what we often find with the index finger, because it's well used, the skin is a lot thicker as well. So again, there's a number of things you can read up in the book. You can get the exact list of things which will count against this. But in essence, by putting a finger into the pulse oximeter, the red light comes on. So that red light in there shines through my finger. And then it gives me a score on here. And that score is how much oxygen is in my blood. And we're looking for a score between 94 to 98 O2. So that's the oxygen. Okay. I've drawn it in red because I'm going to use the opposite of it in blue. So that's the score we're looking at. Now, please be aware that's the score from the JR Calc. So what the paramedics use in out of hospital. When we look at in hospital, we look at often 96 and above. And again, if we look at the news score, so the National Early Warning Score, which is there mainly for sepsis and things like that, but it's used a lot in hospital, they look at 96 and above. And on that score, you score 0 if you've got 96 and above. But for us in the pre-hospital environment, we're looking for 94 to 98% on there. And if it's less than 94%, we can look at giving them supplementary oxygen. That's a whole new subject on its own. So we'll go into that in more detail in another lesson. So that's what we're looking for. So what is the opposite of oxygen? So again, if we think of this as being a measuring tool, so there's just a straight cylinder, and I'm going to fill that with gas. Okay. Well, if 94% of it, so roughly up to here, so all of this here is O2. So all of that is oxygen. So what is left in this last kind of 6%-ish or less, Well, this is the CO2. So this is the carbon dioxide. I don't know if you can see that. Let's just move that around to there. Okay. So, this is the carbon dioxide. This is the oxygen. If I've got 98% oxygen, in essence, I've got 2% carbon dioxide. If I've got 94% oxygen, I've got 6%. That's the simplest way I can explain it. Okay, so that's what we need to think about it, is if we measure our blood, we've got 100% gases in there. We're looking at 94 to 98 being oxygen, which means the other bit of it is the carbon dioxide. So where does the carbon dioxide come from? Because if we measure atmospheric air and see what's around, yes, there's 20.8% oxygen. There's only 0.4% carbon dioxide in this atmosphere around us. That is it. 0.4% oxygen. So when I breathe in 0.4%, let me get them around the right way, 0.4% carbon dioxide. So as I breathe in 21% oxygen. I also breathe in 0.4% carbon dioxide. That's what I breathe in. But when I breathe out, the air that comes out, if I measure that, I've got roughly 16% oxygen that comes out. So I've lost around about 4% of my oxygen. Not lost, I've used it in my body. So I've actually used up 4% of the oxygen. But as we know by this cylinder, that oxygen needs to be replaced by something, which is the carbon dioxide. So when I breathe out, there is 4% carbon dioxide comes out. So think about the numbers. I breathe in air. Within that air, 21% is oxygen, 0.4% is carbon dioxide. When I breathe out 16% oxygen and 4% carbon dioxide. Again, the rest is the nitrogen and maybe a tiny little bit of argon, things like that. But they're the two we're worried about, the oxygen and the carbon dioxide. So where has this carbon dioxide come from? Okay, so I know I've used up 4% oxygen and it's been replaced by carbon dioxide, but where has that come from? Well, that's when we go into cellular activity. So what I'm going to do is just move across to here. And we're going to talk about a cell. So here is a cell. Okay. That cell is one of many cells. So if I think about a blood vessel, I've got a blood vessel coming along. That blood vessel we know will divide off and go to different places, and then they subdivide again, go to different places, etc., etc. When we get down to these lower kind of areas of the cell, and I'm just going to come back to this bit here, sorry, just make sure you can see. When I come back to here, I've got lots of cells on the walls of my blood vessels. So all of these are little cells. Yeah, got cells here, and these could be muscle cells, other cells, different cells that do different things in different organs. Well, each of them is one of these, so I just magnified it. Now, if we think about our blood flowing, yeah, our blood is flowing at the moment in this direction. So let's just bring this back to the bigger kind of picture and see where we're going to start. So I'm going to start here in the left side of the heart. So in the left side of the heart, at the top, I've got the left atria. That is just a collecting chamber. So it collects kind of blood. So if we look at it here, yeah, so here is the left side of the heart. We've got the collecting chamber. There's a valve that it goes through, and it goes into the left ventricle. The left ventricle, as you can see, has got a nice big bit of muscle mass around it. When that squeezes, it ejects blood out, and it goes through this big aorta. Now, the first branch off of the aorta is this one here, which feeds the heart muscle. I'll talk about that in my next video, okay? But you've got to remember that. This aorta then will divide off. So I've got that big aorta, so it's coming out of here. Blood goes this way, then comes out. So this is my big aorta, big blood vessel. Yeah, so big aorta. That then goes down. It goes to all different blood vessels, all different organs within the body, etc., etc., etc. It then breaks all the way down, and it comes in here to the cell. So this is the blood vessel coming here. And remember, what I've got in this blood vessel here is O2. So I know there's 21% O2 traveling through here. Well, in fact, there's a nice little bit where the O2 can come into the cell. So the oxygen is able to transfuse into the cell. Now, the oxygen on its own is not enough. So we've got other stuff which is floating around or being transported by our blood. And another thing that's being transported is glucose. So we've got glucose traveling through, and the glucose gets to here and it can't get across. So we now need a gatekeeper, which is insulin, to let the glucose get through. So the insulin lets the glucose through. So now we've got glucose and O2 in the cell. Them two combine together. Whoosh! Yeah, big explosion. It's not quite as big and dramatic as that, but that is cellular activity. We will do another session on this, which will be when we look at diabetes and insulin and glucose and things like that. So for now, we just need to know that the oxygen can transfer into the cell, but it does need the glucose to work with it. Once the glucose and the O2 have created energy, yeah, so we get cell, we then get the energy, they create a waste product. The waste product from energy is CO2. Carbon dioxide. So that is where carbon dioxide comes from. So it actually comes from the waste product of cellular activity from the oxygen and the glucose creating energy in the cell. It produces CO2. That CO2 then comes out of the cell and needs to be transported. And that is where this will then go in, carrying on in that direction, because this is the CO2. And the reason I've changed colour, this was my arteries coming in, and this is my venous system going back. So this here is internal respiration. So the internal respiration is the exchange of gases at cellular level. Okay, so just make sure you can see that. Yeah, so very quick run through. We breathe. Diaphragm goes down. How does the diaphragm know to come down? I'll talk about that in a second. Diaphragm comes down, creates a vacuum, draws air in. Within the air, 21% oxygen. That oxygen gets to the alveolar. We'll draw that in next. That then gets into the bloodstream. That then goes to the heart. The heart then pumps out of the left ventricle the blood, which is oxygen rich, starting off through the arch of the aorta, breaking its way down to cellular level. When we get down to cellular level, the oxygen can transfer into the cell. We know it needs glucose and a gatekeeper of insulin to let the glucose in, but it's the oxygen we're worried about now. The oxygen combines with the glucose to create energy. The waste product from energy is CO2. CO2 comes out now in my blood vessels, so it's changed from arterial to venous, and that now is going to go where? So that now returns to my heart. So that blood vessel there returns here to the right atria. It then goes down into the right ventricle, and from the right ventricle, it goes off to the lungs. Okay, so that goes off to the lungs. This is the only veins in the body that carry oxygen. Okay, so that's important. So these are the only veins in the body. No, get that around the right way. So these are the only veins that carry carbon dioxide, non-oxygen. These are veins. You know, I would redo this whole video, cancel everything I just said, and I'm now going to get it correct. All right, so forget that. These are arteries because they're being pumped away from the heart. So anything that goes away from the heart is an artery. Anything that goes towards the heart is a vein. So these are the only arteries in the body which carry carbon dioxide. So these are the pulmonary arteries. So they go from the right ventricle to the lungs. They then break down into smaller kind of bits, and they will then come, and I'm going to draw it around this way, to the alveolar. Yeah, so they come to the alveolar. This is now the complete opposite of the cell. This now is the CO2 going into the alveolar, and what comes out of the alveolar, and I've lost my red pen for a second, there it is the oxygen. So the oxygen comes out. So when the CO2 goes into the alveolar, the oxygen comes out. So again, we've got another exchange of gases. So this is external respiration. So this was internal respiration because we had the exchange of gases. This is external respiration because this is the gases exchanging to go externally. So remember, we had a 21% oxygen coming in. When we breathe out, actually there's still 16% oxygen in this blood vessel here. But the important thing is we've got 4% carbon dioxide coming out that we're going to breathe out. This blood vessel, yeah, then is oxygen rich, goes back to the heart, goes to the atria, goes to the ventricle, gets pumped out and around. So there's our circuit. The blood vessels that go this way, because they're going towards the heart, are veins. Anything that goes towards the heart is a vein. Anything that comes away from the heart is an artery. These ones are oxygen rich. So these are the only veins which have got oxygen in. So these are the pulmonary veins. Okay, so the pulmonary veins are rich in oxygen. The pulmonary arteries, which pump away, are low in oxygen, rich in carbon dioxide. I hope that kind of makes sense. That's the basics of it. So the last little bit on this video is, why do we breathe? Well, within our blood vessels, we've got sensors, and those sensors are linked up to the brain through our nervous system. And then there's a link from the brain that comes back to our diaphragm. So we've got a sensor, a chemoreceptor, which measures the level of carbon dioxide. When the carbon dioxide gets up and rises, the sensor reacts a trigger in the brain. The brain then uses the phrenic nerve to tell the diaphragm to lower, and it does. And as it lowers, that whole mechanism that we've been talking about happens. So there is our full basic airway and breathing kind of concept in the easiest kind of way I can describe it. I hope it's made sense. I'm going to go on and talk about the heart next in a different video. But if you've got any questions on this, please send me an email or put it in the group discussion and we can talk about that. But these numbers are important, so you need to know all of this. I hope this has helped. Job's a good one. I will see you on the next video. So let me just stop recording.